We're talking with Dr. Howard Bergman, who's one of the 2014 recipients of the College of Family Physicians of Canada's Lifetime Achievement Awards in Family Medicine Research. Congratulations. Thanks for speaking with us, Dr. Bergman.
Thank you.
Tell me, how did you become involved in research? You're a family physician, also doing research.
Well, actually, my first research project was as a medical student a long time ago. And it was actually something around more basic science with dogs and etc. Inspired actually by a family physician at the time who did this on his own time in the middle of the night, and I would go and assist him with the surgery on dogs. So that's actually how it started, my interest. And I helped found a clinic in a very poor area of Montreal in the late 60s, before there was public Medicare in Quebec or in Canada, and wasn't involved in research then. I was a family physician there, and then got involved in a nursing home as a physician in a nursing home, as well as the primary care physician, and just out of curiosity, actually started a research project to look at what are the factors that explain why patients are sent from the nursing home to the emergency room and what happens to them, and compare it to. And I think that was even published in the Canadian Family Physician, if I remember correctly. So that was sort of the first taste of research, and then I sort of migrated to be involved much more in geriatrics, and got involved in various research projects and programs, and probably the most important one was around a program we developed on integrated care for very frail older persons in Quebec in the late 90s, and that was a very exciting and interesting and groundbreaking in a certain way, and received the publication that came out of that received a lot of attention. So from then on, once you sort of get addicted, it starts and you can't stop. But really, why I got involved in research, why people get involved in research, is because you're curious to know the impact of what you're doing, or you've developed an idea, you want to convince others to adopt that idea, and you have to evaluate it if you want to convince others.
So can I ask you a little bit more about the integrated services for frail elderly people? Right. So tell me a bit more detail about that. What does it really mean, and what it?
Yeah, well, that was a while back, and it was a project that was did with a colleague of mine, François Bélan from the University of Montreal, and what it was to propose a new model of care, where a community-based organization, together with the family physicians, would be responsible clinically and financially for a group of very frail older persons for their entire trajectory of care. So why did we think about that? Because one of the things that I was doing at that time was geriatrics in the hospital, and I would see that we would have elderly people who'd wait in the hospital for days and days and weeks, sometimes months and months. It would be very expensive, just because there was no resources out there. Right. So it didn't make sense from a financial, medical, or human point of view to keep them in the hospital, which is very expensive and not a very useful way of taking care of them. So we said to ourselves, well, what if we were holding the bag of money, where would I put it? I would take it and put it into developing more home care, more alternative housing, supportive housing, et cetera, and get them out of the hospital instead of having them sit in the hospital waiting for something which will never happen, and they deteriorate. So that was the basic idea. Mm-hmm. And it was actually evaluated as a randomized controlled trial. We recruited 1,200 older persons in 2 sites, 600 and 600, 300 intervention, 300 control in 2 sites. It was funded, got an enormous amount of money from the health. It was a new program, and I can't remember the name. Mm-hmm. The Health Transition Fund, okay, which was meant to fund demonstration projects. And there was so much interest that even though it was the amount of money needed was much more than the maximum they were giving, they found a way of actually funding it by funding it as 2 projects, actually. And it was supported both by the Quebec government and by the federal government. It ran for about 23 months, and it received an enormous amount of funding. So it was very, very exciting, both in terms of the intervention itself, right, and in terms of the evaluation. We're talking about $13–14 million in funding, both for the intervention and the evaluation.
Excellent, excellent. You must have put forth quite a good proposal then.
It was.
That's often, I think, the nub of it, isn't it?
Part of that, and part is putting through a good proposal. Part is having a proposal that is relevant to the context. Part of it is being in the right place at the right time. Mm-hmm.
Okay, and you have also worked in dementia care for yes, Quebec Alzheimer's.
Yeah, well, so involved a lot in research. I also was fortunate enough to be involved a lot in health policy. Okay. So I was a member, the only physician member of the Clare Commission, which set up in 1999 by the Quebec government as a royal type commission, mm-hmm, independent commission to examine the healthcare system and propose reforms to the healthcare system in Quebec to the government. And my baby on that commission was the creation of the family medicine groups, which the equivalent of people know in Ontario, the family health teams, right, the medical home before we coined the term medical home. Mm-hmm. So that was my work on that commission, and I'm very proud of it because today probably about 60% of the Quebec population is covered by a family medicine group, and it's growing and growing. The other part of my work in policy was in 2007 or so, the then Quebec Minister of Health, Philippe Couillard, who is now Prime Minister of Quebec, mm-hmm, asked me to chair a task force to propose the Quebec Alzheimer Plan, which I did, and which was the report was tabled in 2009, and it's contrary to the Alzheimer Plan in France or even in England. The Quebec Alzheimer Plan is grounded in primary care and not in specialty care. And I'm very proud of that, and I presented that to a meeting in Tokyo of the G8 countries who are very interested in Alzheimer's disease for the obvious reasons at the present time. And we're unique in Canada, and it shows how strong family medicine is in Canada, that generally the approach to Alzheimer's disease across the different provinces is grounded in primary care, contrary to most countries in the world. And so out of that also, I was involved with the Ministry of Health in implementing some of the important recommendations of that plan, and in setting up what we call the Canadian team for improvement of health services system care, dementia care, mm-hmm, which brings together researchers and stakeholders, including families, caregivers and patients, ministry people, decision makers, clinicians, and healthcare managers. And this also received funding, and we're going to be evaluating implementation of managing Alzheimer's disease in the community in Quebec and Ontario mainly, but with implications for the rest of Canada as well.
Okay. So can I ask, go back a little bit and ask you, tell us a little bit more about the significance of primary care for the elderly and Alzheimer's patients as opposed to specialist care. What's the benefit?
Well, there's actually an interesting tradition, I'll use the word tradition, in Canada. We've had four or five consensus conferences since 1989, consensus conference on dementia. The first, which was actually first started by a family physician, Mark Clarfield. And the idea was to develop consensus around clinical care, et cetera, and treatment for Alzheimer's disease and related disorders like all forms of dementia. But what's interesting is, and there were some family physicians, but there were many neurologists, geriatricians, et cetera. The consensus was since 1989 that it has to be grounded in primary care. Why? Because the primary care physician is the physician who the patients see. Patients see longitudinally, so is in the best position to see changes and development. Also the best position to look after older people in Alzheimer's disease, not only older people, but mainly older people, who have a very bad habit, older people. They have many chronic diseases. Right. So it's not just Alzheimer's, they have other chronic diseases, okay, which a specialist in a memory clinic will not be able to, doesn't want to do. Right. The third reason is a very practical reason. There'll never be enough specialists, enough psychiatrists, geriatricians, neurologists trained and interested in Alzheimer's disease to be able to even evaluate all the people who need some form of evaluation and, of course, of treatment. And finally, the literature shows that the family medicine management of Alzheimer's disease is as good as a memory clinic. The point is not to oppose one or the other. What we're saying is that probably just, in other words, is it the diabetes or the cancer model? Cancer, basically, as soon as somebody sees the cancer, we send it to the specialist. Diabetes, in general, is managed in the primary care. And if it's a complex problem, then it can be referred from primary care to a specialist. So that's the model. So the joke I make is I co-founded and co-led a memory clinic for many years at the Jewish General Hospital, McGill University, the best memory clinic in the world. The best in the world. Except it takes 8 to 12 months to get in, so it may be the best in the world, but not very useful. And why does it take 8 to 12 months to get in? Because 80% of what's done in that memory clinic is primary care. On the other hand, to be fair, many primary care physicians say, oh, dementia, I don't want to touch that. Too complicated. So, how do we make this change? Well, first of all, I think it's very difficult for a solo family physician to do this, and that's why the family health teams, the family medicine groups in Quebec, there's an infrastructure, there's a multidisciplinary team, and can do this complex evaluation and follow-up of patients with Alzheimer's disease and use specialty services when necessary. So it's really a partnership, but probably about 80% of Alzheimer's disease and related disorders don't have to see a specialist.
Right. Okay. So that is one of the tenets, I think, for trying to convince funders and others to support family medicine research, right, both in terms of financials and how do we go about doing more of that and getting that message across that primary care is the place to care for many things in
well, care? So let me, some people say primary care is undervalued, not understood, not appreciated, not funded, primary care research not funded, etc. I was recruited by our dean at McGill University to become chair, and I started about 2.5 years ago. And I think the narrative has changed.
Okay.
The narrative has changed. Provincial ministries of health all understand that primary care and primary care, the way it's given by family health teams and family medicine groups, is the basis for a sustainable healthcare system. It's a priority. In Quebec, it even became an election issue. Nobody was saying, I can't find a cardiac surgeon. I want a primary care physician.
Right.
So funding bodies, and I was actually vice president of the Quebec Health Research Funding Bodies, the FRSQ, for several years. Funding bodies more and more are developing specific funding programs for primary care community-based research. So there is funding. And the third thing is, when Dean Eidelman recruited me, he said, for him, family medicine was an academic priority. It wasn't simply a factory to produce more and more, teach more and more residents, because the government is increasing the number of, the government in Quebec, and I presume in other provinces, the proportion of family medicine residents to other specialty is going from 40-60 to 60-40.
Right.
So I don't think it's true that we're undervalued, and on the contrary. So I think that narrative has changed. And if I look at the commission that I was on in the year 1990, they chose a family physician out of the only physician on this commission. The Minister of Health chose a family physician to write the Quebec Alzheimer plan. So I think the narrative changed. I think the challenge now is not to convince people. The challenge now is to meet the expectations. So now the challenge is be careful what you wish for. Because, and as I've said to my department in front of the dean, I said the dean hasn't given us gifts. He's issued challenges to us, and now we have to produce. And I have to say that our dean, and I see it in other Canadian universities, but I can't speak for every Canadian university, but our dean has been true to his word about saying that family medicine is an academic priority. He's been true to his word verbally in saying it to a lot of people, and also in terms of support and resources that he's given our department. So our department now has approximately close to 10 full-time PhD faculty. Wow. And close to 10 clinician scientists. Now, it's family physicians who spend 50% of the time in clinical work and 80% of their time in research. Mm-hmm. And we now have an accredited research master's program. Mm-hmm. We have a ad hoc PhD program, which the university has now asked us to apply for a fully accredited PhD program. We have over 40 graduate students, MSc, PhD, and postdocs. Mm-hmm. This is with the support of the Faculty of Medicine and our dean. And in fact, even the principal is coming, and just had an exchange of emails with our office. The principal is coming to visit our department, spend a half a day with us in our department. So the narrative's changed. Now it's be careful what you wish for, because you have to meet the expectations that we have created.
How do you do that?
You work bloody hard. You have to make sure you have to produce. And so we have to train young people. we have to, our researchers, and I'm very proud to say, and I'm saying it for McGill, but I'm very proud of family medicine in general, our researchers are very well funded. In Quebec, we have salary awards, which are very, very competitive, and our researchers have been very, both the PhD and the MD research have been very successful. They have lots of graduate students, so they're doing what they're supposed to do.
Okay. So the perception is perhaps a little bit off.
It's maybe a little bit dated, but it might be true in some places. But I think there's really an evolution, and I think it's important that family medicine change that narrative.
Okay.
Because if the narrative has to be linked to the context of the times.
Okay. So one of the things we talk about a lot is capacity building and meeting the challenges with training and education and so on. Sometimes I understand there's hesitancy on the part of physicians or other disciplines to go into research. What would you tell a student now about what research holds for them?
Yeah, well, that's another interesting thing, and it's something that I've noticed because I spend a lot of time speaking to medical students at McGill, trying to attract them to family medicine. We have a family medicine interest group, etc. And we have dinners, and I talk to them about research as a career. And what I find very, very rewarding is we're starting to see, maybe not starting, maybe I've just started to see it, maybe it's been medical students who have an interest in research. So I bumped into a first-year medical student and said to me, I'm interested in research as a career, and I'm interested in family medicine.
Wow.
I said, okay, do you have any backgrounds? I have a PhD in epidemiology. Oh, that's very nice. I said, where'd you get your PhD from? Oxford University. I said, oh, that's very nice. And she happened to be a Rhodes Scholar, etc. But what I'm saying is, we're starting to see that. So medical students who historically, if they wanted to have a research career, would go into internal medicine or surgery or psychiatry. Mm-hmm. But now, and it's part of because of the narrative from the dean, the fact that we have a master's program, etc., the fact we have so many researchers. Now this young student, who's a terrific student, she's going to be attracted by every specialty that she goes through. Mm-hmm. So we have to work hard, so so we've integrated her into one of our research programs, so keep her close and work with her as she goes through medical school. One of the challenges is to interest residents in a research career. We have the Clinical Scholars Program at McGill, and we have pathways to help them if they want. And the other thing that we'd like to do is to interest family doctorate in practice who might want to come back. So I just bumped into Bill Hogg and I said, Bill, you know, you're our poster boy. Because I always give that as the example of somebody who was in practice, went back, got a master's, and has become a premier researcher in Canada. So one of the things we want to do is develop distance learning with our master's program. So a family physician who's, I'm interested, but I can't take off 2 years. They could do it part-time, distance learning over 3 or 4 years.
There are ways to do it.
Yeah.
Good. I think we're just about at our half hour.
Okay. I spoke too much.
No, you didn't. We could probably go on for another 2 or 3 hours.
Right.
There's always fascinating stuff comes out of our chats, and
so
really
maybe I have a
appreciate
different perception, as you see, of what's
You
going
do,
on.
and that's-
Do I have it?
yeah, I think there really is a perception, and I don't know why, having heard you speak, but maybe we don't. Maybe other universities, other people, other jurisdictions don't have the strength of your dean, who really believes.
Yeah. And you know, it's something I didn't say, which I should have said. I'm standing on the shoulders of my predecessors. So Louise Naismith, Martin Dawes, and Miriam Boila, who progressively developed the academic strength of the department. Okay.